All this is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. So thank you very much for joining me on this weekend. I hope that you or on a Friday evening. I hope you have a great weekend ahead. The discussion that I want to do today is the latest in long COVID world, the possible lab values, the possible areas of pathology, and the possible therapeutics. There is a beautiful article that is written by some researchers here in California. The article collects together the definition of long COVID, epidemiology of it, pathophysiology, and then the labs and clinical aspects. So I think it's a beautiful article. If you look at various pathophysiologies, I have covered them, majority of them, except the pulmonary side, in my past videos. So it is really just a compilation in one place. Plus, it is the most up to date at this time in terms of what is going on in long COVID. I would suspect, and so this is my opinion, not the authors, I would suspect that the same spike protein based damage could be associated with the vaccine side effects as well. So maybe these therapies may be useful for the vaccine side effects as well. So I'm going to go over that with you. The second thing is that I am discontinuing these chit chats. The reason for that is I think these were a great tool when we were going through the COVID, and there was a need for having these open discussions and interactive discussions. However, I do not think that at this time these are very valuable for you or for me. I spent almost a whole day preparing for these, and the last few chit chats that I did, the viewer interest was so low that it actually declined the whole channel by 30%. So if you are interested in free long form discussions, and live discussions, then you can join me on Patreon. Patreon is, I think, $3 or $5 per month. And if you find this much of a value, $3 to $5 a month, then you should join there. If you do not find that value, then these content may not be for you anyways. So over there, every Wednesday, we do a 1 p.m. Pacific talk, Zoom live, and then another talk where we repeat the same content for other time zones at 6 p.m. Pacific. So with this, thank you very much for all the long COVID discussions and the chit chats that we have done in the past, and for your time. And from this time onwards, we will not have these long form videos. Okay, so let me now go over the presentation. So this is drbeen.com. There are more medical lectures here if you would like to join there. Then for the discussion today, this is a video that I think will be very useful for anyone who is going through long COVID or vaccine side effects. The video is on this channel where you're seeing the live, over-the-counter therapies for inflammation. So pardon a couple of spelling mistakes in here, that is my fault, but this table can get you started for how to start looking at inflammation from non-allopathic point of view, just the lifestyle and various over-the-counter ways. So here is the article that I want to go over with you, and let me see if I can increase this in size. So the links for everything, including Patreon, etc., are in the description of this video. So this is the mechanism of long COVID and the path towards therapeutics. And if you look at the authors, Division of HIV, Infectious Disease and Global Medicine, University of California, San Francisco, California. So I'm going to go over some parts of it. There is a diagram in here which is invaluable. I believe they have done a great job of collecting together the pathophysiologies, the labs, and the possible remedies in one place. So I wish I had made that kind of a table. So they've done a great job. So here, first of all, they talk about the summary of their discussion. Long COVID, a type of post-acute sequelae of severe acute respiratory syndrome, coronavirus 2, defined by medically unexplained symptoms, following infection with SARS-CoV-2 is a newly recognized infection-associated chronic condition. So IACC, infection-associated chronic condition. There are other viruses, for example, HHV6 or VZV, varicella zoster virus. They also can cause chronic conditions. So these are all together called IACC or infection associated chronic conditions that causes disability in some people. So then they continue and they say, however, there is no cure for the tens of millions of people believed to be experiencing long COVID, and industry engagement in developing therapeutics has been limited. I would actually, so this is my words, I would extend this if I was doing this therapeutics to say similar number or a number from vaccine side effects as well is suffering in the same way, that there is lack of attention for them. Then they say here, we review the current state of knowledge regarding the biology and pathophysiology of long COVID, focusing on how the proposed mechanisms explain the physiology of the syndrome and how they provide a rationale for the implementation of a broad experimental medicine and clinical trials agenda. So this is a beautiful article. Their point of view is the following. If you see the objective of their article, their objective is not to say that here is the pathophysiology and here is the medicine for that, but instead they're putting together groundwork to say, here are the categories of pathophysiologies. We think that following lab values may be of use. We think that the following clinical aspects or therapies, interventions may be of use. However, this is how to think about long COVID when we do more studies. So here they discuss the definition of long COVID, and they discuss that World Health Organization calls it post-COVID-19 condition. US Center for Disease Control calls it post-COVID-19 conditions. The UK calls it post-COVID-19 syndrome. Similarly, Spanish Ministry of Health calls it post-COVID-19. The patients call it long COVID. And then the others, there is a task force that was put together. That was the US National Academics of Sciences, Engineering, and Medicine in 2023-2024. They came back with the following definition. In their report, long COVID is defined as a chronic disease state that may be clinically diagnosed after 3 months of symptoms or diagnosable conditions that affect one or more organ system. Symptoms may vary in severity and can be continuous, relapsing and remitting, or progressive. The authors of this report note the economic or social functional impairment often associated with long COVID, as well as the emotional and physical distress it brings for patients, families, and caregivers. So they have further discussion. And I like every single diagram they have. I love these diagrams. So the first diagram here, in this one, they're saying post-acute sequelae of SARS-CoV-2. And if you have been with me for long COVID discussions or the COVID discussions for the last 4 or 5 years, there was a time when one of the professors of medicine had joined me. And I asked them, I said, what is long COVID? And he said, we should divide that into 2 parts. One is the long post-COVID sequelae. That is if the organ damage has occurred. For example, let's say lung damage occurred. And then there is an outcome of that damage. And then there is the immune system dysregulation, which then causes further symptoms. So I believe that a similar approach is taken here. So if in this diagram, they're saying post-acute sequelae of SARS-CoV-2 can be post-COVID-19 conditions or post-COVID-19 syndrome. So here they say post-hospitalization syndromes. So somebody who had severe enough long COVID that they went to hospital, now they might come out with cardiovascular damage or respiratory system damage or renal damage or other tissues damage, and they are now suffering and recovering from that damage. Or they may have exacerbation of pre-existing medical conditions. So let's say somebody was diabetic, their diabetes became worst, or somebody had a cardiac issue already and now that issue has become exacerbated or more severe, or somebody had, let's say, Epstein-Barr virus and now their EBV has become reactivated. So meaning they had a pre-existing condition which got exacerbated by the COVID. Then incidental medical diagnosis. So they may have some medical diagnosis that was found as they ended up in the hospital or with a doctor with COVID. And then finally, new or worsened symptoms not explained by known medical conditions. So this would be the long COVID, where somebody after COVID, either during the COVID or a few weeks to months after COVID, have developed new unexplainable symptoms, or I would say unattributable symptoms, meaning you can't say as a physician that how come all of a sudden this symptom appeared, what was the cause of it. The patient did not have anything else that you can attribute it to. So then that would be long COVID. Continuing on, epidemiology. So I'm not going to spend too much time on it. There are so many studies that provide varying kind of numbers, and I've discussed them in the past. Here they say that it seems like 30% or greater. Some studies suggest a prevalence of 30% or greater, but define the syndrome as any new unexplained symptoms. Now, I would once again change the word from unexplained to unattributable symptoms. Unexplained means that you cannot explain that symptom. I think that what we are saying is, the article is saying is that symptoms are there. You can see the symptoms, but you cannot explain why they are there. So the cause may be confusing, and that may be long COVID. For the epidemiology, there have been studies. For example, US Veterans Affairs study showed anywhere from 16% to more. Then there was studies from other countries that showed even 30, 40, 50, 60% of the patients with long COVID. I think it depends upon the person's gender, their comorbid conditions, their age, their inflammatory status, their socioeconomic status. So there are multiple statuses that may trigger the long COVID in one group of people more than others. And they do talk about this, that even vaccines do not seem to reduce or do not seem to block from long COVID. The same US Veterans Affairs study that I had actually discussed once in the past, that had said that there is a slight reduction in the long COVID incidence with the vaccines. However, because there is no matching numbers to say vaccine side effects may be this much, and so then you combine the long COVID after long vaccines from COVID, and then if you combine the side effects as well, which we do not even know the epidemiology for those, what is that number? That is still an unknown. The epidemiology of the more disabling forms of the condition is largely unknown. Can you imagine this? We still do not know this. Severe disabling long COVID is uncommon. And why do I say that? I say that because we've spent billions of dollars on COVID and COVID treatments. And we still do not know exactly why the disabling forms of long COVID are the way they are. That is quite disappointing for me. Severe disabling long COVID is uncommon, affecting only a few % of those infected. But even if it is relatively rare, among those exposed to SARS-CoV-2, the syndrome is profoundly important given the impact it can have on health and the fact that nearly everyone might be expected to be exposed to the virus. And I would just further, this is me now, not the authors, I would say spike protein related damage. There may be pathophysiology by the remaining components of the virus, but I believe that the major culprit is the spike protein itself. And I've done lots of studies, discussions in the past about how does spike protein from the virus ends up causing cytokine storm, cardiovascular damage, neurological damage, damage to the respiratory system. I have done those discussions in the past, so it's not necessary to repeat them at this time. So the syndrome is profoundly important given the impact it can have on health and the fact that nearly everyone might be expected to be exposed to the virus. Conservative estimates suggest that there may be over 4 million people with profound disease in the US alone. Even a small risk of long COVID represents a major public health concern. Once again, without attributing it to the authors, this is not what they said. I am saying this, that any source of spike protein could have similar pathophysiology. And the same concern that is here for the long COVID could be applied to everyone with the spike protein injury. The risk factors for developing long COVID have been consistent. Female sex, older age, more severe acute infection, and lower socioeconomic status. The degree to which SARS-CoV-2 variants differ in their capacity to cause long COVID is unknown, but some studies suggest that the risk after Omicron is low relative to Delta and earlier variants. The effect of reinfection is unclear, but at least one study suggests harm. Vaccination is protective but does not fully prevent long COVID. And so they say the further work is needed. Now, this is also a very good diagram. In this diagram, what they are saying is that, look, here are the possibilities of individuals who may be more vulnerable to developing long COVID. Female sex, age 40 to 65, medical comorbidities, for example, obesity, diabetes, etc., more severe infection, pre-Omicron variants, low socioeconomic status, SARS-CoV-2 reinfections, genetic factors. And then they say protection. And I feel, I may be wrong, but when I was reading it, I felt that they said it's not necessary that the protection by the current therapeutics or interventions is whole. And I think one of the example is here. They're saying vaccination is protective but does not fully prevent long COVID. So similarly here, protective vaccination and COVID-19 treatments, you could insert other treatments that you like, but generally the idea is that there are not much interventions that can protect against long COVID. I think they can modulate the risk downwards. So then are the clinical features of long COVID. Where I want to go with this article is that they have a slightly below, they have a table, a diagram with the pathophysiology, labs, and the clinical aspect. So I want to go there. And I feel that if you have long COVID or side effects on the vaccine, that diagram is very useful. So let me just quickly give you an idea of this. This is that diagram. So I believe this diagram is something that you should print and then go discuss with your doctor if you are searching for the solutions. So back here, clinical features can emerge during the acute phase, long COVID, or later after several weeks. The most common symptoms include fatigue, cognitive problems, and post-exertional symptoms. Symptoms can wax and wane. So then, continuing on, several groups have characterized subtypes of long COVID. So what they're saying is that there are many groups of physicians, doctors, agencies who have tried to put together that what is a long COVID, what are the pathophysiologies of these, what tissues or organs are affected, and based on that, can we categorize long COVID types to say this is neurological long COVID or this is musculoskeletal long COVID and so on. And I think that the authors present those types, varying types, but they also seem to be saying that we do not actually have a very good framework for that. And so here is a framework that we propose. So if you see here, they say one such analysis, the analysis to try to figure out what kind of categories of long COVID may be. One such analysis identified 4 endotypes: cardiac, renal, so long COVID that is affecting heart and kidney; respiratory, sleep and anxiety; musculoskeletal and neurologic; and digestive and respiratory. And you could, if you have anyone around you that you have observed for long COVID, it's not necessary that long COVID just falls squarely in these buckets. There is going to be long COVID symptoms with a lot of combinations. So then they say many long COVID symptoms overlap with those seen in other ISCCs, again, infection associated chronic conditions, such as myalgia or myalgic encephalomyelitis, chronic fatigue syndrome, chronic Lyme disease, post giardiasis, post Ebola disease, and others. So they're saying that one other difficulty in trying to figure out this is long COVID or not is that these symptoms overlap with other infectious diseases as well. So then they go to a conceptual framework, and they say, here we propose a conceptual framework that makes a distinction between biology and physiology, which we refer to as the upstream and downstream mechanisms. So what they're saying is, here is COVID, and then COVID can lead to pathologies, for example, mitochondrial damage, for example, antibody-related damage, cardiovascular system damage. But really, the pathology is the dysregulation of various systems, or the cells, immune cells, for example, the blood cells, the clotting system, and then they cause further damage. To give you an example of what they mean by upstream and downstream, imagine that somebody after COVID or after spike injury develops the endothelial damage, or inflammation, which leads to a propensity for microclots within the blood vascular system. Now, when there are microclots within the vascular system, that means that the blood supply, nutritional supply, oxygen supply, and the washing away of the waste products from certain tissues will become hampered or impacted negatively because the blood flow is less now, because the blood vessels are inflamed, and because there are microthrombi present in the blood vessels, occluding them. And so then those tissues would, as a consequence, will start getting damaged. That could be brain tissue damage, that could be muscle damage, that could be liver damage, that could be GIT damage, that is cardiovascular, the heart damage. But that is a secondary aspect. And before that, let's say clotting was happening. So they would call clotting as the upstream and the consequential tissue damage as the downstream. So then, here in this diagram, where I wanted to reach with the discussion today, they are proposing various upstream, downstream, lab, and clinical aspects. So I think this is the most important part of the talk today. So the biological drivers of long COVID are upstream processes, perturbation of immune system, coagulation system, etc., that in and of themselves do not clearly cause the disease. So for example, when the B cells are dysregulated and they're making a lot of antibodies, that in itself is not really the disease or causing the symptoms. You could call it to be the disease because it is a pathology, but that's not causing the symptoms. Those antibodies, when they go to various tissues, including blood vessels, heart, kidney, other places, and they bind there and they cause inflammation there, now those tissues are damaged. Those organs are damaged because of the B cell dysregulation, and now the symptoms are appearing in those organs. So they're saying that these dysregulations of the clotting system, of the immune system, and other such processes would then result in organ damage. So let's look at some of this. So they start from here, the biological mechanisms. The first one is acute infection. So they say research, testing, what do we do, the labs, how do we, they're telling it to researchers as well that, hey, if you are doing a research on long COVID, and if you're trying to figure out if the acute infection is present, then do the following. And then here are the therapeutics. So this is, I'm going to try to make it even bigger if possible. Here. So let's start from here. Acute infection. You're a physician, you are a healthcare professional, you're trying to figure out, or you're a patient, you're trying to figure out, do I have infection or my patient has infection? So COVID-19 testing, viral dynamics. Therapeutics, vaccinations, antivirals, monoclonals, metformin, anti-inflammatories, antiplatelets, anticoagulants, and we have been discussing this from ever for last 4 years. So you could actually look at this channel and there are tons of videos about these. Then virus persistence. So on this side, these are the possibilities that may cause long COVID. So you may have to identify what problems do I have? Or for your patient, you may have to identify what problems, what pathologies do they have. So let's say the second possible pathology is virus persistence. And it is so interesting for me that when I was teaching COVID in the early years, I had seen various studies that showed the viral debris to be present in, for example, in fecal matter, the mRNA pieces to be present in fecal matter, but not the viable virus itself. That is the same situation even today, that there has not been any study or studies that have deterministically proved that there is a persistent virus sitting somewhere. So that is still a mystery. But imagine that if you feel that there is viral persistence, then they say, look at the blood antigens. So the antigens, remember when there is virus, we produce antigens against the virus. So those antigens should be detectable in the blood. Blood PCR from the PCR and tissue biopsy. You could do a GIT tissue biopsy if possible, or pulmonary biopsy or lymph node biopsy and see if the virus is present. And then therapeutics, what are the solutions? Vaccination, COVID-19 antivirals, monoclonals. And once again, you can insert your own favorite therapies over here. The point for me is not to say, here is what they say and what you should do. The point here is that they have created a table. You can update this table with your experience or with your studies that you have read and add them there. I like the structure here. Then post-acute inflammation. This is another important thing to notice, that in long COVID, of course, there is continuous inflammation that is happening. Remember, long COVID sequelae is the tissue, the organ damage that happened when the acute infection was there. For example, let's say pulmonary damage. And now the pulmonary damage has caused the lung tissue to, for example, shrink or become scarred. And that tissue isn't performing as well as before. So this is not a long COVID from some process dysregulation. This is long COVID because of the tissue damage. So post-acute inflammation, how do we find out that there is inflammation? CRP, C-reactive protein. What is C-reactive protein? When there is inflammation present in our tissue, the tissue starts producing cytokines and chemokines, which are molecules that are either signaling molecules or they are the fighting molecules. Then those molecules can go to liver and they can trigger the liver to produce even more proteins. One kind of a protein that is called acute phase reactant produced, which are many proteins. One of those proteins by liver is C-reactive protein. And C-reactive protein has been traditionally used to understand the presence of inflammation in a person. John says, did they say to take vaccine for long COVID? Correct, John. So they do say for therapeutics. And when I was discussing the long COVID in the past, there had been some folks even on this channel who would come in sometimes and say, I had the long COVID and I got another booster and it felt better. So it is possible that in some individuals, there may be viral persistence or there may be mRNA persistence, or there may be B cells that are producing antibodies against the spike protein, which is then causing anti-idiotypical antibodies, which I've done, I think, about 3 or 4 videos about it, where there is an antibody against the antibody, which looks like spike protein then, and then that can act as a spike protein. And in this case, if you have given a booster, it is possible that the spike proteins would come and bind with those antibodies and those complexes will be washed out and the patient would feel better. I would suspect a similar thing would happen if they got infected again, but the risk with the infection vaccine. So I'm not going to get into those discussions. I just want to make sure that we can see the structure and we can formulate our own tables if we like. So post-acute inflammation, blood markers, C-reactive protein, cellular immunology proteomics. What does that mean? Proteomics is the proteins, measuring those proteins that are released from the immune cells. For example, interleukin 1, interleukin 6, interleukin 10, tumor necrosis factor alpha, GM-CSF, granulocyte, monocyte, colony stimulating factor, etc. So these are proteomics. These are the proteins released by the immune cells, which can tell you if the immune cells are active and causing inflammation. Radiographic imaging, PET scan, MRI, CTs, ultrasounds, or imaging, X-rays, to see what tissue's status is and what is going on there. Tissue biopsies. So this is for post-acute inflammation. And how do we help if there is inflammation? I would actually request you to watch, to look at, and this is not a sneaky way to sell you my Drbeen access, but at Drbeen, if you go to courses, I did a set of lectures about various inflammatory pathways and what over-the-counter remedies or what supplements may be helpful for that. So if you see here, JAK-STAT pathway, I've discussed that as a lecture 6. So if I go back to this study here, they're saying for controlling the inflammation, you may want to inhibit JAK-STAT pathways, interleukin inhibitors, which you may have heard from Dr. Bruce Patterson, various inhibitors he uses, inflammasome inhibitors, checkpoint inhibitors, rapamycin. Rapamycin is a very interesting drug because it kind of reduces these immune system dysregulated cells or their behaviors. So these are some, these are some possibilities for therapeutics. These are just some. If you look at immune system dysregulation, you can look at the macrophage activation syndromes. You can see mast cell activation syndromes. You can see the B cells, the memory B cells that are sitting in the bone marrow and are making anti-idiotypical antibodies, and their behavior is totally different. You can see the activated T cells or the memory cells and the cytotoxic T cells. So there are multiple kind of problems that can be present in immune dysregulation. I think that is the largest area of dysregulation for chronic inflammations. And there is a lot of research. Rheumatology is the whole branch of science, medical sciences, that tries to figure that out. So these proteomics and these interventions are just examples here. One can actually expand on that. I could probably write a chapter or more just to discuss this one row over here. So then moving on from that one, autoimmunity. We have seen this as well in the case of long COVIDs, that patient could develop autoimmunity. And that autoimmunity, as I discussed before, look, the most important concept that I would like us to keep in mind, and I've discussed this before, imagine that there is a B cell here. And this B cell got converted into a plasma cell. Plasma cell means a cell that is active B cell, and it is making antibodies, and it is releasing those antibodies out in the interstitial fluids, and then from there into the blood, and then those antibodies are going everywhere, hoping to fight with whatever they would attack, virus or the spike protein. However, these activated B cells would also make memory cells. So imagine that this is a memory cell. This memory cell can have multiple locations to live. The first location is that this memory cell can live in the area of infection. For example, let's say you develop sore throat and there is some pathogen over there. Let's say SARS-CoV-2. It is in the nasal cavity and the throat. Then the B cells that live in that vicinity may have the memory B cells that are sitting there for future attacks and to respond to them. So that is one possibility of where these memory cells would go. The second possibility is that these memory cells would live in the regional lymph nodes. So the lymph nodes that are present near the nose and throat, for example, cervical lymph nodes, these B cells can go and live there. The third possibility is that these B cells would start circulating in the blood and go to various other tissues to see if there is a intruder there, if there is the offensive agent present there, and then make antibodies near them. So that is circulating B cells, and you can actually measure them by taking blood from a person. And fourth, and the most dangerous one, is when these B cells go to bone marrow and start living there. This is where the problem becomes really bad. Why? The number 1, 2, and 3, these B cells would go away if they're not triggered again. They'll go away within 2-3 years. The local lymph nodes, regional B cells and the lymph node B cells would perish away within 2-3 years, or really be very few in number. Circulating B cells would go away as well, even earlier. But those B cells that have gone to the bone marrow, they can go and live there for 20, 30 years, even till the end of our life. So once they are there and they are now producing antibodies from there, you don't have much control on these B cells. And because bone marrow is a very active tissue, where all the cytokines and remember I said granulocyte, monocyte, colony stimulating factors, there are so many stimulating factors that are produced by any inflammation, any other viral inflammation, any other bacterial inflammation, any other inflammation because of tissue injury or stress or whatever. Those cytokines will come into the bone marrow and they would kick the bone marrow to say, hey, produce more cells, produce more inflammatory cells. In that process, these B cells can become activated. That is a very similar process with the EBV reactivation as well. And so now these B cells can continue to produce these antibodies. And if there is anti-idiotypical antibodies, anti-idiotype antibodies, and I have done this discussion. There is a paper by Dr. Bill Murphy, by Dr. William Murphy, who discussed the discovery of anti-idiotype antibodies in long COVID patients and even in the acute patients. What he found was, and his team found was, in acute COVID patients, these antibodies would go away at some point, but in long COVID, they would sustain. So these antibodies are going to look similar in their binding sites to spike protein. And so now these antibodies are being produced by the B cell and are released in the blood, where they are acting like minor spike proteins, and they might cause inflammations here and there, and they might even bind to ACE2 to create a similar outcome like a spike protein. So back here, autoimmunity can be of many types. One is these B cells living in the bone marrow. The other one is T cells, cytotoxic T cells, and their memory cells sitting somewhere. Then it is also possible that some other autoimmunity, for example, let's say the EBV virus reactivation is very common, at least from the studies that I've read, in the long COVID patients. Then other autoimmune disorders can become triggered as well. Excuse me. So autoimmunity, how do you know that there is autoimmunity? Blood markers, for example, anti-nuclear antibodies. And if you go to my channel, this channel, Dr. Bean's channel, this one that you're watching this video on, and if you look for how do anti-nuclear antibodies develop, you would see that video where I discuss that. So I am kind of amazed that majority of my body of work that I did in last 3 years covers majority of the topics that they have over here. You can have explanation of every single topic present here from the videos that I've done already. So here, blood markers, anti-nuclear antibodies, autoantibody testing. Remember the anti-ACE2 antibodies that are done by a company in Germany. B cell testing for the memory B cells and the B cells that are going, not behaving correctly, right? So disordered B cell or the memory B cells. Then how do you fix this? IVIG, plasmapheresis, B cell depletion. So I had this discussion. So let me just very quickly, IVIG, you take antibodies from the community and you inject them into a person, hoping that those antibodies would clear out the antibodies that are produced by these rude and rogue B cells. But as you can see, the IVIG will go and complex with these antibodies and try to clear them out. But that doesn't mean it would remove the B cells. So after a few weeks to months, the B cells would still be active, so the pathology would come back. This is a temporary solution. Then the plasmapheresis. Plasmapheresis is another method where you take the person's blood and you try to clear out the antibodies that are present there. Again, as you can tell, that would be a temporary solution because the B cells that are producing these things are not going away. So the problem would come back after a few weeks to months. And then the third one is B cell depletion. So I had a very important discussion that I did with Dr. Bill Murphy on this channel. It is present, that where I discussed with him, I remember my question, although it is years ago, but I still remember my question. And that question was, does this seem like to get rid of the long COVID, we will have to do bone marrow suppression or bone marrow bounce? So you kill the bone marrow, which we do in cancers, and then you replenish the bone marrow. Would that then trigger remove those B cells? Meaning, my question to him was, what are the ways to get rid of these B cells that are now sitting in the bone marrow for the life of us and just going to keep producing these antibodies and keep making our life miserable? So you can hear his answer, but he had a similar answer that, yeah, they're going to be attempts to try to get rid of those. So here they use the word B cell depletion. From this article and the latest interventions, I feel happy that all the discussions that I have done in the past, they actually compile up to everything over here and more. So if you ever wanted to have a discussion of why these things may be useful or what these therapies mean, the videos are on this channel, which is very interesting. Then is the thrombosis. I have done the discussions around thrombosis a lot. I did that with the cytokine storms. I did that with the blood clotting. I did that with the, remember the Oxford, AstraZeneca, and then Johnson & Johnson, and the women under 50 years of age were more vulnerable to developing clotting problems with those vaccines. So I had done those mechanistic discussions in the past, only to get lots of heat and pushback and hate because I was discussing it. But these are important scientific studies and mechanisms that we should know. So here, thrombosis. How do you know that microclots or clots are going on in the blood? So of course, fibrinogen and D dimers are important to look at. Then microclot assays are great to look at. Microclots are slightly different from general regular clots. So this was Dr. Razia Pretorius of South Africa who started this discussion of microclots present in the blood vessels, which do not melt away like the remaining clots, and why they're stuck to the blood vessels, etc. So I partially agree with her. There are some things that I think are correct, and there are some things that I think she is not correct in those. But anyways, microclots is another possibility of smaller clots that are more sticky. So the solutions, and I have to give this disclaimer here. I'm sure that similar disclaimer by these authors as well. This is not a medical advice. This is actually a framework to start thinking about how to solve a patient's problem who may have long COVID. That is what, or a researcher who's trying to research long COVID. I have added my opinion on it, that any vaccine injury, may that be from the COVID or from other reasons, could also be looked at with the similar lens, with the same lens actually. So here, antiplatelet drugs, and this is why I gave the disclaimer, antiplatelet drugs or drugs that would cause blood thinning can cause strokes and other problems as well, bleedings as well. So one has to be careful, and you have to talk with your doctor to do that. It's not that you just go over the counter aspirin and you're taking that. That could become really harmful. So talk with the doctor. But antiplatelet drugs, anticoagulants, thrombolytics, and plasmapheresis. So I feel that the microclots aren't going to be very, very much removed by the plasmapheresis, although Dr. Razia Pretorius and her team does do plasmapheresis. And she's the one who actually started that, and then lots of other journals and articles, worked with her, wrote her articles. So um, you can say that she's the leader in this area, in this therapy, or who introduced this therapy. I believe she was the one. Although, once again, I do not agree with some of her mechanistic approaches. Anyway, so thrombosis is another pathology, and here are the labs and here are the possible solutions. Then latent virus reactivation. And I have done more than 5 or 6 videos about Epstein-Barr virus reactivation, EBV reactivation. And I've discussed the mechanism by which the COVID-related immune dysregulation can result in EBV reactivation. That is also present on Drbeen, and it is present for free on this channel as well. So latent virus reactivations, for example, EBV reactivation, varicella zoster virus reactivation, herpesvirus reactivation. And so what are the solutions for them? Antivirals, EBV cellular therapies. And we know that these are not very successful, otherwise we would not have EBV reactivations. But virus reactivations are possible as part of long COVID because of this chaos that may be happening in the bone marrow. And EBV related B cells are sitting here as well. They get reactivated by all this signaling and inflammation or inflammatory cytokines going on there. I've done the discussion of the mechanisms before. So then this one, dysbiosis and gut translocation. I think out of all my videos, this may be the area where I spoke the least. And that is the gut dysbiosis. So here, let me just quickly talk about a couple of mechanisms. One mechanism, let's say this is the colon of a person, and there are bacteria that live here, the microbiome. The COVID-19 is known to actually alter our microbiome. Now, microbiome, latest research shows, is responsible to keep a healthy or unhealthy state in us because it contributes the cytokines. So what it does is the microbiome works with the local immune cells. Those immune cells in turn would produce cytokines that would go throughout the body. And that is how the gut bacteria or microbiome can actually create a healthy or unhealthy environment in the rest of our body. The second problem that can happen is that when microbiome is imbalanced, or let's say healthy microbiome is now converted to less healthy microbiome, the result of that is that the gut lining or the epithelial surfaces can become inflamed. When these are inflamed, they become leaky. And what happens is, if you look at epithelial surfaces mean epithelial cells mean the surface cells. So your skin cells are epithelial cells. If you look into your mouth, the cells that are making that surface is epithelial cell. If you look inside your nose, the cells that are making that surface are epithelial cells. If you look at the surface of your eye, these are epithelial cells. The urinary system, epithelial cell. The vaginal system, epithelial cells. The whole GIT is epithelial cells. And because these are surface cells, they have to be really, really sure that they would not let anything pass between them, because on one side they are facing a lumen. So let's say this is gut where all the food and fecal matter and the bacteria are sitting. And then let's say this is the tissue side where there is blood vessels here. It is the duty of the epithelial cells to create a barrier so things do not just leak out into the tissues. That would be horrible, right? However, leaky gut is a known phenomena. So what happens is that these epithelial cells, when they're sitting together, they are kind of pressed against each other. You imagine yourself sitting next to another person and you're kind of pressed against each other. You're kind of body to body, forcing yourself side to side with each other. And not only that, there are actually proteins that weld these two cells together tightly. So for example, these are cadherines, or these are zonulin, or cadherin, and similar other proteins are present. These proteins kind of weld these cells together so that this space between the cell is not available to other molecules to pass through. However, when the epithelium becomes inflamed, one outcome of that inflammation is that these proteins break down because the cells are sick. And because the cells are sick, they cannot make those proteins, they cannot maintain those proteins. So when those proteins start breaking down, the cells cannot stay tightly bound to each other, and the space appears between them. This is leaky gut. And from this space, the things from the GIT can now leak into our tissues. From there, they can go to the blood, they can then go to the rest of the body, they can go to brain, and they can cause all kinds of problems. So the gut dysbiosis, the microbiome dysbiosis by COVID-19, and the resulting damage to the epithelial surfaces, and then the resulting damage in the systemics in our body is also a contributor to the long COVID. So here, dysbiosis and gut translocation, microbial markers. So how do we know there is something like that going on? Beta glucans, lipopolysaccharides. So what happens is that in here, in the microbiome here, there are two big categories of bacteria that sit here, gram negatives and gram positives. In the gram negative, there are two big categories, parvotellas and bacteroides. The parvotella are the most commonly offensive agents when the inflammations happen. Normally, they are a happy little cell bacteria that is helping us. But the gram-negative bacteria, so if I make a little, I'm going to make it a happy bacteria because it's going to try to help us. That is what the role of the microbiome is. These bacteria have on their outer side lipopolysaccharides, if I am spelling them correctly. If not, just assume that I'm a doctor and I don't spell things correctly. Lipopolysaccharides, they are lipids in the cell membrane of the bacteria or cell wall, which are connected with the saccharides. Saccharides are sugars, so they are connected with the sugars. This little structure is the poison by this bacteria that it can release in the local environment, and this is called LPS. LPS is a very common inflammatory and offensive agent that is even used in the research to trigger the macrophages and the neutrophils and the other cells when the researchers want those cells to be triggered and then observe their behavior. They treat them with LPS, and LPS just drives them crazy. So what they're saying is that these LPS, when the microbiome is not in the correct balance, then it is possible that the gram-negative bacteria will increase and they'll produce a lot of lipopolysaccharide, which would cause local inflammation, which would then cause the leaky gut to occur. So here, how do you know that there is a gut dysbiosis and translocations happening, or the gut linings are injured? Microbial markers. So you can see from the blood of the patient, the markers of the bacteria that should be present in the gut, present in the circulation now. Then beta glucans. So these are also the bacterial products. Lipopolysaccharides are those two. And then if you see zonulins are those little welding proteins. When these welding proteins are broken down, they will be released back into the tissues and in the circulation as well, and you can measure them. They would be released in the fecal side as well, and you can measure them. So then look at this fecal microbiota. You could do an analysis on the microbiota to say what is going on within the colon and rectum of this person. So imagine that there is inflammatory state in the GIT of this person, especially the colorectal area. Then you can offer probiotics. Then larazotide. Larazotide is a very interesting it is called zonulin antagonist, but generally it is something that would protect the zonulin from breaking down. So it keeps the epithelial barrier integrity of the GIT intact. So it helps reduce the leaky gut symptoms. It is actually used in the irritable bowel syndrome, or I believe celiac disease, it is used for the same purpose. So it is possible that lorazotide or lorazotide is given to help against the leaky gut. But once again, please remember, when you give lorazotide, for example, to help against a leaky gut, that would only help against these cells breaking down. That is not going to come in and say, you know what, I'm going to take away the cause of the problem or the inflammation itself. It is just going to take away some consequence of the inflammation to provide the symptomatic relief to the patient, while you as a physician or healthcare provider try to figure out how to solve the remaining problem with the microbiota dysregulation. And then finally, so there is a question. Janice says, why did the CDC suddenly decide in 21 to change the definition? Are we still stuck in those kind of rhetorical things? The CDC had to change the definition of vaccines because they introduced a new platform that was called messenger RNA vaccine. So previous vaccines did not have that. I remember this. As much as I feel that there are vaccine side effects, and I feel that there is not enough attention to the people who are vaccine injured, I remember British Medical Journal's editor coined this problem that somehow the usage of mRNA into the vaccine is somehow a problem that has occurred. I think that is the least of our worries. The bigger problem is, what do we do now? So back here, mitochondrial dysfunction. This is a huge problem as well. And I feel this is a fundamental, just like the clotting or the vascular inflammation is a problem, just like the autoantibodies or the B cell, memory B cells is a problem. I feel that in the processes, as they call them, upstream issues, mitochondrial damage is another huge problem. Mitochondrial damage can be the basis of a lot of tissue damage. For example, let's just look at it for a second. Let's say this is a happy little tissue. Let's say this is a brain tissue, some part of the brain tissue. Do you know that the tissue in the brain that gets most damaged by or affected by long COVID or similar spike protein issues is the hippocampal area, which is then related to memory formations and memory judgments, and to say what will become memory. So this is why patients start feeling, the hippocampus is also involved in the cognitive functions. And this is why patients of these diseases start developing cognitive decline or brain fog, plus they start having problem with the memory formation, because the memory forming tissue is the most impacted by this inflammatory state. And if you said why, there are two reasons for that. The one reason is that because there may be inflammation of the blood vessels, which is then bringing in less blood and nutrition and oxygen and washing away less waste products and less carbon dioxide and less acids and less creatinines, that causes the tissue to start getting damaged. And the second problem is that the hippocampus is an area in the brain where we make 500 new neurons every day. There are 500 neurons that die, and the 500 new neurons are formed in hippocampus every day. That is called neurogenesis. There are stem cells in the hippocampus that make new neurons. So when you are not providing it appropriate nutrition, and when there are inflammatory molecules that are crossing the blood-brain barrier and coming in, they affect the area where new neurons are formed. And so those new neurons get damaged, plus the brain, the stem cells that make the neurons, they get damaged, and you start making less neurons. So now neurons are dying every day, but new neurons are not produced with the same rate. And then we have a hippocampal shrinkage. Remember that there was a study that came from Oxford about the COVID, that even after 1 year of acute COVID, there was a 5% shrinkage in the brain tissue because of those inflammatory states and the tissue damage. So where was I here? Okay, mitochondrial damage. What happens is that, imagine that this is brain tissue. And imagine that this is a blood vessel that is bringing, nutrition and oxygen. This is an artery. And then here is a vein that is taking away carbon dioxide and the waste products, etc. Now imagine that there are microclots present in this system. Imagine the endothelium is inflamed. So that means lesser of the um, oxygen and nutrition is coming in, correct? That would do what? That would cause the tissue to start, the cells to start becoming stressed. And once again, I am not trying to sell you things. I've never tried to do it. I did this lecture here, cell stressor states and fates, in this inflammation course, where I discussed that what are various kind of stressors and what happens to the cell when those stressors are present. For example, in this case, less oxygen is present, less nutrition is present, more waste products are piling up around the cell. What will happen? So I've discussed that. And then I've discussed the hypoxia-inducible factor, which you would see here. So now what happens is, as there is less oxygen, there will be hypoxia that is here. There is less oxygen that is here. And hypoxia-inducible factor or an inflammatory pathway would become activated, which would then cause damage to the local tissues by causing inflammation. Similarly, the very important thing is that when there is less oxygen, the mitochondria would start getting damaged. Remember, mitochondria work with oxygen to help create ATP. And so when there is less oxygen, number one, the glycolysis would start, which is non-oxidative glycolysis or just simple glycolysis. And then number two, the mitochondria themselves would start getting damaged, which would then in turn not only reduce the production of ATP, but mitochondria that are damaged are becoming very, very upset, and they would start doing fragmentation. They would start releasing inflammatory molecules. Those inflammatory molecules would tell the cell to die. They can trigger apoptosis. They can try to trigger autophagy. They can release inflammatory molecules that would go and cause the other immune system cells to become activated and start killing the other cells. Mitochondrial damage is a real horrible situation. And I had done this discussion. Let's see, what did they say about the mitochondrial damage? Amino acids, N-acetylcysteine or NAC, metformin, and I would add a couple of more things that are interesting over here. And I've done those discussions in the past. Near infrared light is like a magical cure for some of the mitochondrial pathologies. Near infrared light has photons in them. And mitochondria, so let's say this is a mitochondria. Let's say this is a mitochondria, and there is this electron transport chain. If I make the electron transport chain here, we have complex 1, 2, complex 3, 4, and then ATP synthase. If I increase the size of this. So there are millions of electron transport chains sitting over here. Complex 4. So let me back up for a second. When the mitochondria is damaged, this electron transport chain isn't working correctly. And these systems are, imagine this was an assembly line and final output is ATP. These systems start becoming clogged. So when you give near infrared light, number one, near infrared light can penetrate 4 inches into our body tissues, including through the bones and your clothes. Number two, the complex 4 of the mitochondria is a chromophore. A chromophore is an enzyme that can work with light, just like chloroplast in the leaves can work with the lights. Similarly, our mitochondria has chromophores in them. They have metals in them that can react to light and take their photons. So if you give near infrared light, the complex 4 is going to take the photons from there and then use those photons to start kickstarting this complex, the ATP synthase, and the system would start working. Hydrogen would start going out and it would come in and ATP will be formed. So even when the remaining 3 complexes are disabled, just these 2 would start working and the mitochondria would start becoming rehabilitated. And I had done these discussions. You can find them on this channel as well. So in the mitochondrial function and mitochondrial damage and near infrared light, those are the titles. You can see those videos there. But here, mitochondrial dysfunction. So how do you know that there is mitochondrial dysfunction going on? Mitochondrial proteins, for example, cytochrome C, CoQ10, and other mitochondrial DNA, RNA products can be measured in the tissues to see if there is a damage to mitochondria that is happening. Then there are other startups that are now doing mitochondrial fragmentation measurements, etc. So mitochondrial function can be assessed. So mitochondrial proteins, reactive oxygen species. Remember that we had done this discussion as well, that when the complex 2 isn't working correctly, let's say the CoQ10 isn't available correctly. Remember, when the mitochondria is not functioning correctly or when there is inflammation, we're going to use a lot of CoQ10. CoQ10 helps the mitochondria work with the reactive oxygen species and kind of neutralize them. About 5% of the overall energy that passes through the mitochondrial electron transport chain is converted into reactive oxygen species, and we have various kind of enzymes that can help neutralize those species. In one of them is the endosomes as well, and the other one are CoQ10 and some other superoxide dismutases and other such neutralizing enzymes. However, when CoQ10 is lesser, when it is used up during inflammation, then what happens is that a larger amount of reactive oxygen species start escaping the electron transport chain, which would now they would overwhelm the cell's neutralizing systems. And as a result, they would start causing damage to mitochondria. Then they would start causing damage to the cell in which the mitochondria is present. And then they would cause inflammation outside as well as the cell starts becoming damaged. So, of course, then you can look at the mitochondrial proteins. You can look at the reactive oxygen species. You can do a muscle biopsy to see what is the state of the mitochondria. And then how do you solve that? Amino acid therapies, NAC therapy, metformin, near infrared light, etc. So then what they do is, I'm going to stop this article here, but I want to show you still that if you look at the article, they continue on with various targets and they show them on a map to say for SARS-CoV-2, here are various targets of the drugs that would be useful at various stages. If there is an immunological problem, then look at this steroids here, JAK-STAT here, IL-6 inhibitors here, Razotide here, IVIG. So they have given a map as well. I would suspect that you would print out this map and go discuss with your physician to say, hey, look, here are the possibilities. Why not we try to figure out what's going on and then see how to fix them? And if the physician says, how do I know what is going on? I'm sure that they know. Then you would say, here is a table for the kind of labs we can run. And then if you continue down this article, they go over every single aspect. Excuse me, my throat dried for speaking. They go over every single aspect of these pathophysiologies, and then they talk about the possible solutions. They give references to various studies that they have taken this data from. So I had actually marked. So in my manuscript marking, if you look at the structure, how they present that is, for example, let's say reactivation of the latent viral infections. So first they talk about what that means. Then they talk about various studies that demonstrate that this happens. And then finally, they talk about the solutions that we have already discussed. But I just wanted you to kind of be aware of the structure of this article. So if you wanted to give it a read, you're aware how to navigate this system. So then there are some other discussions here as well. This is the pathophysiological, immunological, and inflammatory features of long COVID. This is also a more recent study, 2024, but I think most of that we have already covered here. Then here is another study, long COVID, molecular mechanisms and detection techniques. So once again, I think in that bigger article, this is covered. Then here is another long COVID clinical update. So these links are present in the description of this video in case you wanted to go through them. And I would suspect that if you would love to know more, I would recommend this YouTube channel because I have mechanisms for everyone of these therapies and these, not therapies, but these pathologies, their mechanisms. And plus you might want to take access to this course for the inflammatory pathways. So this is the discussion. I wanted to make sure that my last chit chat is valuable to you. And if you would like to continue with these kind of discussions, join me on Patreon. At least here, when I do long form videos, they actually damage the channel because people watch them less, and the YouTube thinks that nobody is interested in this channel. YouTube stop recommending. And my just last 4 or 5 chit chats, the channel went down 30%. So on the Patreon, it's really $3 or $5 a month. And if $3 or $5 is too expensive for you for this kind of a content, then this content is not for you anyways. So otherwise, on this channel, this is the last chit chat. I will not be doing further chit chats. All right. So now let's talk. Roller Girl says, crying face. I'm so sorry, Roller Girl, but within 1 month, the channel went down 30%. Just because there is less interest in these long form videos. And I don't blame anyone. It's just that this is not the. During COVID, it was a needed service, and I did that service for talking every day for 3-4 hours and preparing for 10 hours. And I think this is not the right time to do that. But if somebody still wants it, Patreon is over. So that at least makes it worth my while as well, because I can have some compensation for the time I put in this. Plus, you have a chance to have an open Zoom talk. Your mic is open. You're discussing things with me, and while we are discussing various mechanisms. Races, I understand. It's been great. Thanks. You're very welcome. Samina says, can you start on dengue? Samina, I usually try to stay within the framework that I have decided. For example, I'm working on the nutrition and aging and cholesterols and those. If I get a chance, I'll do it. So Leroy says, I think you're shadow banned. So either shadow banned or my audience doesn't like these long form videos. So they have lesser interest in them. Even today, when I was looking at my channel, YouTube actually wrote to me. It's so funny that so check this out here. If I hide my face, then you can see it. So it says, if I read it, regular viewers are watching this video for a shorter amount of time than usual, contributing to 39% fewer views. So their recommendation is make more interesting videos for the audience. So I think that it's a combined effect. It's the audience as well that are not interested in some of these topics, longer topics. Sigrid says, will lufimectin expect that anything that reduces inflammation will do that? And for that, I request you that please watch this video. This is over-the-counter therapies for inflammation. I have created a framework that even yesterday when I was discussing, there is a new study that came out that says that the gut dysbiosis of Prevotella virus causes either the colorectal cancer risk to increase or the Alzheimer's disease risk to increase. And as I was discussing that how to manage that kind of a situation, because we're in a hard spot, rock in a hard spot, because either one is going to increase or the other is going to increase. So we get increase of one of them. These inflammatory pathway modulators came in handy. So this table is a gem. So I would request you to look at this table. So yes, anything that is going to reduce the inflammation, anything that can hamper these spike proteins behavior or SARS-CoV-2's behavior would help. And as you can see that it really depends upon the kind of pathology. For example, if the pathology is that the B cells are dysregulated, then the lufimectin type thing can help with the anti-idiotypical antibodies, but who's going to take care of those B cells? Imagine if there is an endothelial damage. So sure, we can kind of block the ACE2s from getting damaged by the lufimectin-like thing, but who is going to fix the inflammatory state of the blood vessels? Or if the mitochondria are damaged, who is going to help with that? So there is going to be a combined attack on the pathologies that would create the effect. What I'm seeing is that most of the time, the physicians or the patients, they are targeting one point, let's say just the mitochondrial damage. And now the B cells are free to do whatever endothelial damage is still present. The microclots are going on, the cardiovascular system, the sympathetic system, the parasympathetic system, they're not working correctly. The peripheral neuropathies are happening. The myelin sheath is getting damaged while we are looking at the mitochondria. So that's just one part, right? So one has to combine the therapies. This is why this table of mine plus the table in this article is really important to see what are the possible areas and what therapies should be present. And from this table, you can see some of those over-the-counter therapies, and then how do we combine them to start helping, again, talking with your doctor first. I wish that your doctor is aware and read up enough. Paul says, thank you for the years of service to us. You're very welcome. Patty, I'm so sorry about that. I'm very, very sorry. Praying for you and your family and for your health. Mubin, have you heard about Lyme and Bartonella reactivation as well? I have not heard about the Bartonella reactivation, but Lyme for sure. Yes. Olga says, thank you for all your hard work. You've blessed us with your past 4 years. I'm a long COVID patient and I greatly benefit from your chit chat. You're very welcome. I think that this article that I was presenting today, that if you look at that framework and then see what can you do, either lifestyle, some people don't like to take medicines, so they can look at their lifestyle to see how do I help it, or supplements or the foods or allopathic medicines, they can really benefit from that. Happy Days says, thank you for the last few years of the most thorough and understandable explanations available. You're one of a kind. Bless you. Thank you very much. My only request to the audience is that when you see my smaller videos, like them, watch them, maybe comment on them, and keep helping the channel. Carolyn says, you've helped me immensely. I subscribe because of all the information you give us freely. Thank you. Thank you. You're very welcome. It was a pleasure. And I would still continue to do it. The direction would be slightly different. But my request to you is please keep helping me grow. Appreciate all the information. You're very welcome. Samina says, nutrition in relation to endometriosis. So I have this vitamin D series going on at this time. We'll do that. And then I'll see if I can do this nutrition and endometriosis. That's a good topic. Roller, you're very welcome. Guy, shorts, most definitely. Absolutely. And Bonnie says, thank you for your services to humanity. You were the part of safety in our COVID storm. Thank you very much. I am blessed to be of service at that time. We all needed help, including myself. So it was good. Spike in exosomes. So yeah, I have actually done the discussions about that as well. The point of the spike has been a very interesting one, and there have been some studies. For example, I discussed the presence of the mRNA in mother's milk, but the question was the quantity and what would that do to the GIT of the baby, because GITs are very well protected. Babies actually would eat things that are probably going to be more harmful than some mRNA pieces. The meats and other things would have a lot of mRNA, many other tissues, or the baby may not eat meat, breast feeding baby. But The other research that I did a lot was the exosome and the spike and the sweat, and I did not find any study that could actually prove that there is exosome in there, or the sweat has a spike protein. Similarly, saliva. So saliva and this area can have spike proteins that are present. And I also discuss how mucosal barrier kind of destroys the spike proteins. So beautiful area, Ellen, and I have done talks about it, which are present free on this channel. Terrorists are among us is saying no more licking pens. Absolutely. Man, that was funny. Olga says that carnivore diet has helped me so much. Very good. Guy says, how about a Halloween special? Absolutely, we can do them. I'm saying that on a regular basis. I don't want to set your expectation. Maybe every once in a while we'll do a long, chit chat and have a discussion, but these would become special occasions. So sure. Roller Girl says, Dr. Bean, I have a picture of you on my phone to cheer me up since 2020. Thank you very much. And I remember from this, somebody from Sweden or Switzerland had sent me the picture of a rock on their path. So what they did was they painted that picture and wrote Dr. Bean on it and put it on the path. And they said, we see this every day we walk. So that was very kind of them. So Shodan says, is it possible to test for spike protein within the tissue? So the tissue is composed of the cells and the interstitial spaces, the spaces between or amongst the cells. If the spike protein is present outside of the cells and in the interstitial fluids, then it would leak into the bloodstream as well. And then you can do anti-ACE2 antibodies, which are, what is that company's name in Germany? Celltrends.de. So Celltrends, I believe, is a company in Germany that do anti-ACE2 antibodies or spike protein like detection if there are anti-idiotypical antibodies. However, if the spike is within the cell, then I do not know if there are any biopsy-based testings available for general public. But I would suspect if the spike is within the cell, then it's going to come out of the cell as well, because the cell is going to get damaged, it's going to break open, the spike is going to spill out, and then you can measure that in the interstitium and the blood circulation. Kingpin says, is your wife's V injury recovered? So almost 99%. She gets 1 or 2 days relapses every few months, but generally she is thankfully fine. It's not the case for many, which is a sad thing, but she's okay. Ellen says, I have spike in exosomes, just tested starting plasma freeze. It's very good. And once again, presence of spike in exosomes and the presence of spike in the blood circulation means that the spike is being produced somewhere. So you can clear the plasma to reduce the quantity of the spikes, to reduce the damage and give some symptomatic relief to the patient. But wherever the factory of the spikes is, eventually we have to reach that nest and figure that out, that what are we going to do. So that I'm not seeing a lot of solutions or interventions that are developed for that. But this is definitely going to help. BR says, please don't stop the chit chats. So one way, BR, is to join me on every Wednesday, 1 p.m. Pacific time and 6 p.m. Pacific time on Patreon. And we do a similar discussion. The difference is that your mic is open as well. And so you can have a bilateral discussion. Over here, you tell me, either the audience supports this channel through, let's say, either buy me a coffee or becoming members of the YouTube enough that when the long form videos are not seen very much and the channel goes down, that is kind of made up from another way. Otherwise, it's really difficult because channel just keeps going down. What YouTube does is it keeps choking your throat. If the channel goes down, it would stop recommending even more, which would make channel go down further, and it puts you in a death spiral to crash you. So I hope that you are well wisher of the channel and don't want it to be crashed fully. So copied often says, how can we shift the media ecology around injury and incorrect priming? T cell exhaustion and other issues people are facing after the fact. How can the errors in approach be reproached collectively? So it's a very interesting problem. A couple of things that comes to my mind, which kind of boils my brain. And talking about boiling my brain, somebody incorrectly put a comment on Trustpilot that I charged them a fee for practicing. I don't practice. And they put a comment there saying, this guy cost me $600. I don't even practice here. So if you can be kind enough, go to Trustpilot and maybe put in a good comment over there if you like this work. So the couple of things that make me really mad. One, there was a study from Oxford. Actually, let me show you that study. And this is, I'm showing you that study in service of the question that you've asked. So Oxford study, that was the modified mRNA and ribosomal slippage vaccine, this one. So if you see the study, N1 methyl pseudouridylation of mRNA causes +1 ribosomal frame shifting. This is December 2023. And as you can see markings on it, meaning I actually discussed it in one of the videos that I did earlier. So you can find those videos. This particular study is, and look at this, people. MRC Toxicology Unit, University of Cambridge. You would see Oxford in here as well, Liverpool here as well. So there are NHR, Oxford Biomedical Research, meaning good researching, good organizations and good researchers. They came up and they said, look, we have found that there are ribosomal slippage on the messenger RNA, modified messenger RNA in the vaccines, which causes the spike protein, if you look at this diagram here, which causes, instead of a whole spike protein to be formed, it causes fragmentation of the spike protein, which could become antigenic and cause a problem. So they then said that we have found a solution. And so they give near the end of it that how to solve that. And I thought, man, this is such an important breakthrough that reduces the risk of any side effects. Maybe let's say this particular problem contributes to 2% of the vaccine injuries, or 10%, or 5%. They would rush to fix this to reduce that. And somebody had presented this study to the inventors of the spike protein as well in Moderna and Pfizer side, BioNTech. And they just simply said, very interesting data, thank you. I thought that they would say, stop everything, let's fix this one, because all they said was for this messenger RNA not to slip, you just insert some blank spaces. It could have been done in 2 days. And I found that there was no interest in doing that. Similarly, a couple of weeks ago or a month ago, there was a new study that came in by, I think, supported by NIH or some other bigger organization, government organization, quasi-government organization, that had come out and said, we have for sure determined that there are some vaccine injury. But they wrote in their manuscript, as I was reading, and they were giving various kind of vaccine injuries and their percentages, they said it is difficult to know how much is the vaccine injury because there aren't enough studies. And yeah, sure, there are not enough studies because you never let anybody study that. Whoever would talk about it, you would punish him. Imagine if I'll go somewhere to a funder to say, I want to do this study for the vaccine injury. I want to see if the spike protein is in the saliva of the people who are vaccinated. I won't get funding. And if I did create that study, I will not get published. And if I did get published in some, remote journal, I will be called as a anti-vaxxer who printed in a third-rate journal. Then these researchers, the quasi-government agency, had the nerve to then come out and say, well, there aren't enough studies. So because of that, maybe we don't have enough data. So your question copied often, I don't think that the US medical system, which is under the influence of other interest than patient welfare, is ready and can be changed quickly to take an about turn from looking at the money to working for the patient. So as much as I would love that this all becomes fixed, I don't think it will. And the terrible thing is we have left the patients to fight on so many fronts. Number one, fight their pathology, feel that they don't have a life anymore of a healthy person, then fight the society, which blames them that you may be anti-vaxxer or you may be making up stuff. Then fight the government who's not ready to support them. These poor people, even imagine vaccine side effects are really rare. There are just total 100 people in the US. Let's take that. It should be so easy to support 100 people. They don't have to drag themselves in that state to go and fight everywhere and to sue the companies and the sue government to get some justice back for them. I cannot imagine that this is happening in the US. And so, copied often, I have no idea how to fix this. I am disappointed and discouraged at the US medical system and the way it is captured. So, Guy says short clips of your education drawings live from your previous videos. That is true. And I would be doing lectures every Thursday and Friday. It's just that I won't do live chit chats very often. And I hope that you would see them and you would like them and you would play them and you would comment on them to support me. Instead of saying, okay, he doesn't do live anymore, I'm not going to talk with him anymore. Paul says that you understand the situation well. Thank you for understanding. You're very welcome. To show you, if you search on my channel, I did a multiple set of videos on a study that was also printed in, I believe, in Nature. That was it was from Los Angeles. The study was POTS incidence after COVID versus vaccine. The whole study is filled with deceptive stats. I did many videos to present those deceptions. And I was criticizing a mainstream journal who allowed a flawed pro-vaccine study to be published. I'm totally happy that if an anti-vaccine study is flawed, which we have just so many unskilled, self-appointed scientists in the anti-vaccine camps that have only made this whole scenario and landscape even worse by their idiotic messaging, which is easy to be dismissed. And then the whole community, medical community, just looks at that and says, you guys are talking these kind of things. You are just not good enough to talk with. That POT study had a similar pro-vaccine idiotic analysis, and I pointed it out. And I remember someone on my behalf reached out to the authors and they simply said, he doesn't know how to look at studies. But they did get enough pressure that they did a correction, but even that correction contained deceptions. And today, this morning, one of the cool beans sent me an article that showed, let me see if I can find it, that showed that how much the peer reviewers, I think from 2020 till 22 or 3, $2.5 billion were spent by these big pharmas and the industry on peer reviewers. Let me show you this. You'll be blown away. I was thinking of doing a separate talk about it. So let me see. So just give me one quick second. Look at this. I'm going to share my screen. Okay, so med page, Medscape, JAMA. Sadly, it is for purchase only. It was open for me in the morning. I'm going to open up my Microsoft. Okay, so maybe look at this. Peer reviewers. Am I sharing my screen? Yes. Peer reviewers have financial conflicts too. Majority reviewing for top medical journals had conflicts and they made 1 billion in 3 years. So let me share that link here in the chat. It's not in the video description because it just came up as an answer to $1 billion in 3 years for the peer reviewing. And they talk about among nearly 2,000 physicians, peer reviewers at JAMA, the New England Journal of Medicine, the BMJ, the Lancet, 58.9% received at least one industry payment during this period, including 54% who accepted general payments and 31.8% who accepted research payments. And if you see here, the 1.06 billion in industry payment included 1 billion to physicians or their institutions and 64.18 billion, 6% in general payments. They do agree at the end that we cannot say if those payments actually swayed the peer reviewing process or not. But you tell me, you take 2,000 physicians and you give them $1 billion, and then you say, well, they are very neutral peer reviewers. This is how bad our system is set up. So, John, I just shared it. Qubit says, just turning in, what did I miss? So one, I will not be doing these regular Friday chit chats anymore because those long form videos, right now it is 1 hour, 38 minutes. Nobody's watching them. And that causes the channel to go down. I would have Patreon. There is $3 per month, I think, or $5 per month. And you can become member there. Every Wednesday, I do a talk at 1 p.m. Pacific and 6 p.m. Pacific. And it goes on for a couple of hours and your mic is open and you're interacting with me and we just talk about various studies and various mechanisms. But this channel is just when people don't take interest in a video, then YouTube algorithm thinks that I am making crappy content, and then YouTube does not recommend it to others and it just keeps going down. So I had a 30% decline in channel overall state in last 1 month because of long videos. So I'm going to maybe keep the chit chats for special occasions, but we will not do chit chats. But I will be doing regular shorter videos, and I hope that you would like and you would comment and you would interact with me through them as well. Leroy says we need you in the White House to fix the conflicts of interest. The White House, whoever comes in, is going to be backed by the industry's people to continue their interest. Teresa Ramanga says, make sure you do videos on current stuff too. Absolutely, we'll do. Absolutely. So, how do I pronounce your name? Zilgoskas TV? Yes. So, many connective tissue diseases can actually become aggravated by the inflammatory states, by the autoimmune states. So, yes, I'm aware of this. Will rewatching help? Yes. Faraz says Japanese professor sacked and papers withdrawn for 10 years of fraud, getting millions in funding. Yeah. Mohammed says the most recent lies of JAMA is the cancer breast and Rayon X, which it was possible, prohibited in Switzerland. Very interesting. So we've been going on for 1 hour and 40 minutes. I hope that the first 58 minutes was useful for the long COVID patients. And then the remaining is just we talking. For us, as corruption has hamstrung society's advancement in all areas, I think that not just the hampered the advancement. Could you imagine? I'm only going to talk about America because I'm here. I do not want to comment on other countries. Could you imagine America doing this to its own people? What it did? I cannot believe it. And still happening to its own people. Its own people. So that means even American well-being, Americans, humans' well-being is not as superior as the monetary interests are. And that just totally ruins my days and nights. Julie Edrick says, had real COVID in Jan 2020 has reactivated chronic fatigue system problems, was under check now, severe again, regardless what I do. So look at these therapies that this manuscript puts together and see if a combination can help. Normally, what I see is just so sorry, terrorists are among us. Just attacking one area is not sufficient. There has to be a combination to help various kind of pathologies in one go. Paul Menton says the life expectancy in America has started to decline. Yeah. So did you see that study that came out, I think, a week or so ago, where it said that scientists are saying that the maximum life expectancy we have reached there. So now they're saying, you know what, we're just going to try to maintain you in this and no more help. So it's just really strange. So anything else? Derek says it's worse when you have long COVID. Absolutely, I know it's a horrible thing. I have friends who have long COVIDs or vaccine side effects. Yeah, this is a good message by Ray. This video only has 15 likes. Oh man, please help Dr. Bean and like this video. And yes, please watch out for my other videos that will come in. Don't ignore them. Watch them, like them, comment on them. So let's make this goodbye now for the long long videos. And the short videos, I'll be there. Maybe I'll even do some short lives with you. But these long chit chats, I'm happy, I'm blessed that I was able to serve you at the time when we all needed that service. And if it was not me, it could have been anyone else. I am happy that during that time and even now, out of all the presenters, there is no one who does mechanism discussion better than what was done on this channel. So that was the unique advantage with which I served you. And so I'm happy that I was able to do it. So with this, thank you very much. Have a nice weekend. Thank you for your time. Almost 2 hours now. Um, so Jean says, would a paid channel that addresses and new studies on long COVID hot topics be interest? I was actually thinking of creating, so you know that on this channel as well, you could create a membership and then have videos or lives only for the members. um, I thought about that. It definitely would benefit me and offset what happens when the algorithm punishes me. But I'm not sure how many folks are actually interested in that. If they are, this could be a way of working through this. Um, for us is, do you do buy me a coffee? Yes. So even in this video's description, you would see Substack, Patreon, and buy me a coffee links. So thank you very much, Carolyn. So Roller Girl says, I tried to set up the Zoom to walk, but could not get it. Sorry about that. So we'll do a Zoom walk tomorrow at 7 a.m. Pacific time. Thank you. And um, I am so sorry. See her long COVID CFS horror time. Yes, it is really, really tough. And I do not know how to. So these chit chat videos, one advantage I have is that I just doodle and talk. And that kind of, you can drive me in any direction. And I am blessed that I can go in some of these directions. And that kind of keeps a very unstructured, but to your direction. When I do planned videos separately and record them, they are just my own topic that I think about. So there is a value in these one, but there is a damage that is occurring as well. I do not know how to reconcile it. If I ask that please support it enough that that damage is offset, then that looks, people start calling me grifter and they start calling me names for that. Some would come in and say, your education should be free for everyone. But I have to eventually pay my bills as well and make sure that the channel is not impacted. So happy to do these talks. I would love to. I just have not figured out a way. This is why I tried again for last 1 month, because I was feeling guilty that I'm not doing them. And then the channel took 30% hit once more. So I'll keep working on it. Um, I'll try to figure out ways. So with this, thank you. Have a nice weekend and talk to you again. So Leroy says, I'm doing a Patreon. So I do have a Patreon, and the link is present in the description of this video as well. Let me see if I can get you the link right now. Patreon used to give me some funds that were able to afford my work. However, lately Patreon has gone down by 60%. So that means that, and I don't blame anyone. It's just that people are not interested. The interest that was necessary at the time of COVID, I understand it. And it's not necessary that everybody is just now interested and continuously has to be interested or have to be interested in medical and these topics. But anyways, I did paste the Patreon. It's Mubin Sayed on Patreon. And the link is in the description as well. And I just pasted it in the chat as well. Joanne says, thank you sincerely. Muhammad says, you deserve all the possible support, Dr. Bean. Thank you. Sita says, we love the doodles and talk. So we have to either find a way that I can be, the channel I this work can be supported once a week. Imagine if you are hiring me for once a week, one day, or I have to figure out how do I sustain instead of just going down. So Guy Telfer says, I'm interested. So I put the link there. Um, so with this, once again, thank you very much. Keep healthy. The book, yes. So book, the good news is that many of the chapters of the book are done. And I am now hopeful that in another few months, because the book has to be written, then it has to be revised and revised and revised, then the diagrams to be added. But the first few chapters are written. So hopefully soon we'll have the book out as well. Thank you. So my latest paintings, this is one. I did these paintings at the Russian Ridge here in California. C Hut says, are you still on FLCCC? So yes, the videos that I did for FLCCC that are still present on their site. Roller Girl says it's you and the knowledge that. Thank you very much. It's actually really a passion to serve that then allows me to read and read and read and then present. You get the in this 1 hour, you get the tip of the iceberg from all the reading I've done for you and kind of collected that information, and then I present it to you. You become the beneficiary of connecting the dots and presenting all of that. Muhammad says, my latest discovery is a beautiful fish. Very nice. BR says that previous videos did better because timing was predictable. So these chit chats are still every Friday at 6 o'clock. So timing is still predictable. It's just the interest is different. And I have no complaint. I understand it. Acha, Patty, that is very nice. So yes, I'm here in Cupertino. So with this, once again, have a nice weekend, and we'll keep, there's a question. How about a quick survey of people here as to what topics they would like and would be Patreon for? That's an interesting question. So we have about 143 people here. What would you like on the Patreon? What kind of topics? Topics I would like and would be patrons for. I understand. So someday we should actually do a gathering as well, get together as well, and have coffee together. Teresa Ramangas is saying cafe. So I was thinking of moving these to cafe. The question is, I think that nobody's going to come to cafe. I would be sitting there alone, or maybe 5 or 10 people. Otherwise, we can try it on cafe. So if others are curious, I have another channel called Cool Beans, one word, Cool Beans Cafe. We were thinking of actually doing these long videos there, but there are not enough subscribers that I think I'll just be there by myself talking about things. Copied often says, studies, mechanisms, trends, and discussions. Teresa Ramagas is saying aging, nutrition, inflammation. Inflammation, we all have to master inflammation. It has to be our primary knowledge set. Everything else stems from inflammation, and every disease causes inflammation. So we have to, and it is not very difficult to master or start understanding what is inflammation, how do we approach inflammation, what are the over the counter or lifestyle choices to kind of help with that. So Sorry, I had to
Okay.
tell Alexa to do something. So, neuropathy, yes, neuropathy is very important. Cool Bean Cafe. We can look at Cool Bean Cafe. Let me see if I can share that link here. If there is a Cool Beans Cafe live, this is the link to Cool Beans Cafe. If this is something that you would like to give it a try, that we move these away from this channel onto the Cool Beans Cafe channel, I'm happy to test it over there. Faraz says, is there a Google Calendar with all your Zooms and YouTubes? I don't always read emails. So very simple. The only 2 days that I'm not on Zoom or YouTube for general population is Monday and Tuesday. I take the Monday's day without any lectures to take care of the business. On Tuesday, I do a live Zoom talk for Dr. Bean paid members. On Wednesday, I do a 1 o'clock and a 6 o'clock live Zoom talks for Patreon, Substack, and YouTube members. And these, for us, you are very often present in there as well. A couple of hours per session, and we just open the mic and we do doodle and look at studies. And that, I think that those talks are actually like gems. I'm sorry, I'm kind of praising my own work, but I discuss so many of the inflammation related things and the well being related things that I think as many people can hear it is good. Then Thursday and Friday are YouTube. Sita says, nutrition is always good. Um, Faraz says, no bell on this page. So if I look at this channel, this is how this channel looks. So if you do become a member on here, don't be worried about these. So these are, any channel member is one of these beans. So because it is Cool Beans Cafe, so you can subscribe to it. And then there is a bell as well. So maybe we should try Cool Beans Cafe, because I have this sincere feeling to be able to serve in these areas, and love to do the chit chats as well. I would love to spend time with you all, my friends. I just have to make sure I don't get obliterated in that process. Seahut says bioregulators, please. Okay. Okay. So I am honestly ready to give it a try on Cool Beans Cafe. So how about we do this? Next week, we'll do a chit chat on Cool Beans Cafe. So make sure that you're there. Maybe what I'll do is this: I'll put the video, premium for Cool Beans Cafe, and I'll put the link in a post for this channel. So you could see that in the post and kind of click on it. Seahut says, just joined the Cool Beans Cafe. Thank you very much. And still, if you would like to support my work and would like to have this bi-directional, mic so open discussions, then Wednesday is a very good day as well. And I do the same session twice so that people who can join at various time, they can. And that supports me as well. $3 or $5 for one person, but if there are sufficient number of people, that supports my time and bills as well. Faraz, thanks, Dr. B. Sincere thanks to you for your company. Absolutely. Marcy says the pulses in the Tuesday and Wednesday talks are the sense of community and support we get from Dr. Bean and the attendees. Thank you very much, Marcy. The pluses. I read that as pulses. Sorry, pluses, yes. Teresa among us says that other have a long channel, short clips channel. So maybe that's what we'll do. We'll go to Cool Beans Cafe and we'll do the long talks over there. And we'll do Patreon if you would like to support this work as well. And then here we'll keep them for shorter videos. So Roller Girl says Cool Bean Cafe, what day and time? So how about we plan for next Friday, same time, 6 p.m. Pacific, the same time, but that channel. I'm gonna try it this coming Friday. Gene says lifestyle, aging, neuropsychology, neurobiology, regenerative medicine, genomic, pharmacy, microbiome, health, new studies, long COVID, everything. Sure, happy to do that. Teresa Ramaga says cafe can be fun channel to pimp this one and the other products. Absolutely. So funny thing that usually for the others, I just read the first word in their name. But if I just read that, that just says terrorist. So I have to read the whole one. Okay, so next week, we're going to give it a try on Cool Beans Cafe. And once again, I would request you to join me on Patreon as well. It would support my work, and $3 a month for one person may not be big, but once there are sufficient people, that helps. And then we'll go from there. So next Friday, Cool Beans Cafe, 6 p.m. Pacific, the same time here. We'll do a chit chat. Bye for now. Correct. Friday at 6 p.m. Let me just quickly see next Friday. Okay, so not next Friday. I am actually flying out. Um, what should I do? I will actually be in Minnesota next Friday. I'm going to go meet a friend. Is it okay if we do it in 2 weeks on 25th? Will you forget me by that time? So the Friday after the next one? Okay, so let's do it on Friday, the 25th of October, 6 p.m. Pacific. Terrorist among us says, fine, you're forgiven. Thank you. No worries, BR. No worries at all. Bye, Roller Girl. 10:25, 6 p.m. Correct. Perfect. So I'll see you on Cool Beans Cafe next Friday, the Friday after the next Friday, on 25th at 6 p.m. Bambi, yes, please. I would love to have you. Okay, excellent. Last time. Bye bye. See you the week after the next.